evening, everyone, and welcome to this edition of Woo You, a closer look at neurotrophic keratitis, ensuring a timely diagnosis and taking early action with Dr. Melissa Barnett. Thank you so much for being here, Dr. Barnett.
Oh, thank you so much. And thanks to everyone for joining us tonight.
Yes, thank you for making Woo You part of your Tuesday evening. And I'm Elise Kramer, joining you from Miami. Where are you joining us from tonight, Dr. Barnett?
From Northern California, from
Like,
Davis.
I guess it's still daytime there, right?
It is.
Next slide. So this is a 1 hour CE course. So in order to obtain CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, there will be a survey link in the chat, and you'll also see the survey appear toward the end of the webinar. You will get CE certificates via email within 4 weeks, but there's also going to be a QR code at the end of the presentation. So if you have the OE Tracker app, you can scan that to get instant CE. You won't be able to use the regular camera on your smartphone. You will need that OE Tracker app. But if you don't have it, you'll still get the CE certificate via email. If you need to ask questions tonight, keep the logistics questions for our team in the chat. But if you have questions for Dr. Barnett, put them in Q&A. And if we have time toward the end of the presentation, we'll be able to go over questions together. Next slide. If you're using the mobile version, it's a little bit different. You'll see the Q&A at the top for our speaker. And if you want to ask questions in the chat, you'll have to click on those three dots at the bottom for more options. Next slide. I will introduce our wonderful speaker who really doesn't need an introduction. But Dr. Melissa Barnett is a world-renowned key opinion leader recognized for her expertise in dry eye disease, specialty in scleral lenses, keratoconus, and presbyopia. She has authored more than 300 articles and books, delivered over 500 lectures, is a board member and founding member of the Intrepid Eye Society, and serves on several industry boards. Dr. Barnett is the author and editor of Specialty Contact Lenses and Contemporary Scleral Lenses, Theory and Application. And if you haven't read it, highly recommend. It's amazing, which features insights and contributions from leading international experts. Her work has been featured in medical journals, professional magazines, as well as consumer publications such as the Washington Post, Bloomberg Prevention Magazine, and Good Housekeeping. Dr. Barnett is a certified professional life coach with a focus on mindful leadership, wellness, and public speaking. She empowers individuals to become their best selves in their personal and professional lives. She is energized by her passion for helping people improve their lives by optimizing their vision, health, and wellness with a customized approach. I always have so much to learn from you, and I always learn so much. So I'm really excited to hear you speak, and I'll be on later on for questions.
Oh, well, thank you so much for the kind introduction. And again, thank you all for joining. Here are my financial disclosures, and none of them have to do with anything in this presentation tonight. So here we're looking at neurotrophic keratitis, ensuring timely diagnosis and taking early action. Please connect with me on all the social platforms. I do have a podcast called Clearly KC with the National Keratoconus Foundation. I am on all the socials, so if you have any questions, feel free to connect, and I look forward to seeing you there. So let's start with some brand new information. I always love lecturing because I'm always learning. So TFOS DUES 3 was recently published, and this is actually a journal pre-proof that I'm sharing with you tonight. And this is the diagnosis aspect of it. So this plays a role when we talk about NK. When I talk to our colleagues and we talk about dry eye disease, I find that some people right now, because we have so many things going on, find that it's a little bit confusing, but I like to take it that it's actually really exciting because we have new diagnostic technology, we have new therapeutics, we have in-office procedures, we have all these different things that we can do. But the really important thing here that we're going to talk about tonight is NK. And when is it dry eye and when is it NK? And hopefully, if there's one thing you take away from tonight, you're going to go back to your clinic and I'm going to send you back with a little bit of homework, but you're going to know the difference. This is looking at TFOS DUES 3. and the differential diagnosis. So again, this is a bit of a busy slide. There's a lot going on here. But if you look kind of down here in the lower right-hand side, you can see neurotrophic keratopathy, which has decreased corneal sensitivity, and that's a key point. So we want to be checking corneal sensitivity in our patients. I was talking to some colleagues the other day, and we're having a conversation about should we be checking corneal sensitivity in all of our patients? And I'm going to let you think about that when we talk about some of the differentials when it comes to NK. So let's get started with NK pathophysiology. So NK, or neurotrophic keratitis, results from impaired corneal innervation that leads to the dysregulation of corneal function. So it's characterized by that lack of sensation. So when you have a patient who comes in, their cornea looks horrible. They have staining, they could have an epithelial defect, their eye is red, it's irritated, and they come in and say, "Oh, everything's fine. I just can't see." We need to be thinking, "Oh, is this NK?" So it's that lack of neuronal homeostasis leading to corneal epithelial breakdown, and ultimately it can lead to an epithelial defect. And we'll go into different classification in just a moment. So NK is characterized by a corneal sensitivity reduction, that's spontaneous epithelial breakdown, and impaired corneal healing. So in my career, I've been in different corneal settings, some with quite a bit of neurotrophic keratitis. And one patient that comes to mind that really taught me so much, and our patients really teach us so much, is a man who was diagnosed with diabetes many years ago, non-contact lens wearer, which is a little bit unusual in my clinic, and comes in because his eye's red and he can't see. Looking at his eye, this is not his eye, but it looks like that upper image, as you can see here. He had a huge epithelial defect. We cultured, everything came back negative. The other thing was a prior history of cataract surgery and diagnosed with NK. So from this one patient, I do believe it's important to check corneal sensitivity in all of our patients with diabetes, and we'll get into some other conditions in just a moment here as well. So we want to avoid getting to the point of corneal melting, corneal perforation. We want to maintain that ocular surface with the beautiful homeostasis of the tear film. So the clinical presentation of NK can really vary quite a bit. When you have someone who comes in with decreased corneal sensitivity, but little or no pain at all, when you see these little slight, sometimes epithelial irregularities with or without an epithelial defect, there can be staining. The staining can be mild, even in NK. And when we get to an epithelial defect, which we don't want to get to, they're typically oval in shape and can have smooth rolled edges, but they can be really variable. They can look very different. And again, we never ever want to get to the melting of the cornea nor perforation. Corneal epithelial cells are really important. They maintain that integrity and function of the corneal epithelium. Limbal stem cells, as we know, divide asymmetrically to produce additional cells, and then epithelial cells as they come out of the limbus. And when I'm live and in person, and maybe some of you can do Pac-Man noises here, I'm not very good at singing or anything like that, but I always think about Pac-Man when I'm talking about the release of neurotrophins and the release of the growth factors. So just think about your little Pac-Man noise here. And this helps with that corneal homeostasis. In a normal cornea, in a healthy cornea, it's avascular. It's extremely sensitive to pain. That's why if you get a bit of dust in your eye or sand in your eye, it's very irritating, or even an eyelash in your eye, right? And we also have corneal sensory nerves that originate from the ophthalmic branch of the fifth cranial nerve The trigeminal nerve bundles lose their perineurium, I can never say that word, and myelin sheaths when they enter the corneal stroma at the corneoscleral limbus. And that's why the cornea is transparent. Kind of interesting things here. Corneal nerves react to injury at the ocular surface and they register even small amounts of pain or irritation. Do you ever have patients who come in and they say, "Oh, my eye is painful." I had a patient today. I had so much pain. And in those cases, I always like to ask, what type of pain are you experiencing? Is it like a sharp stabbing pain? Is it more of a dull ache? And then I also ask, is it localized? Do you feel it in one specific location? Or is it kind of this diffuse pain that you're experiencing? But asking about eye pain, if someone comes in, especially for an acute visit, is very, very helpful. Corneal nerves trigger protective reflexes like tear production and blinking. Whenever I say blinking, we all need to blink more, right? We blink 60% less when we're on digital devices, like all of us are right now. And corneal nerves release those neuromediators and they provide the nutritional or trophic support to the corneal epithelial cells and the keratocytes. There are different mechanisms that are altered with damaged corneal sensory nerves, which leads to impaired corneal renewal and healing and reduced tear formation. So we do need to talk about tear film homeostasis. I hope that many of you are starting to love the tear film. The tear film's amazing with all the different factors that creates this smooth surface, and it really helps protect the cornea. The tear film and that beautiful homeostasis or natural balance of the tear film also is the first refracting surface. So even if someone does not wear contact lenses nor glasses, if they want to see clearly, it's important to have that beautiful tear film homeostasis. So what I've been doing is talking to my patients about tear film homeostasis and the natural balance of the tear film. I talk to them about why it's important to optimize that tear film. And this could be really for anyone. I did have a patient today that I had that conversation with, but it's important for vision. Blurry or fluctuating vision is so common when we're talking about dry eye disease and even NK. We want to get the most clear and comfortable vision that we can. So there's this dynamic interplay. So we have the epithelial cells and keratocytes, we have the corneal sensory nerves, we have the lacrimal gland, and they all work together in order to maintain that beautiful homeostasis or natural balance of the tear film. So what are some of the barriers to diagnosis? And the delays in diagnosing patients with NK can be due to multiple reasons. One is that some of us are not thinking about NK on a day-to-day basis. It's classified as an orphan disease, although it's relatively common in people who have a history of herpetic keratitis or herpes zoster, 6% and 13%. We always need to be thinking about a herpetic condition. There's a lack of symptoms in our patients. There's a discrepancy between the clinical signs and symptoms. Patients are coming in saying, you know, I have blurry, fluctuating vision, perhaps. I can't see clearly. My eye's red versus, and you look at their eye, oh, wow, there's a lot of staining. There could be an epithelial defect. And there are many different conditions that can play a role in NK, and we'll get to those in just a moment here. Damage to the corneal nerves can disrupt corneal homeostasis and can lead to NK. So we can have impairment of trigeminal reflexes, impairment of the nourishment, impaired corneal healing, corneal epithelial alterations, that reduction in tear film production and blink rate, which can lead to spontaneous epithelial breakdown and NK. So, what are some of the etiologies of NK? There's so many different etiologies, and we always need to be thinking about herpetic infection. I always think, well, if I don't know what it is, think, could it be herpes? Could it be a herpetic infection? But there are many other ones too. Systemic diabetes, I truly believe the neuropathy that people with diabetes have, say, in their feet. It's the same thing when we think about their eyes. So we do need to be checking corneal sensitivity in people with a history of diabetes. There are many other systemic conditions like multiple sclerosis, vitamin A deficiency, which is not incredibly common in the US, but it's still there, leprosy. We can think about other CNS conditions like neoplasm or aneurysm, stroke or TBI. And these are actually much more common just in the general population. We see these in clinic all the time. When we go to ocular, and I'll get to some of these in just a moment. Let's switch on to this slide here. But we're going to talk about contact lens wear. So this could be any type of contact lens. It could be a soft contact lens. It could be a corneal gas permeable lens. It could be a scleral lens, any type of contact lens wear and abuse. So think of patients who abuse their contact lenses. They wear a daily replacement lens for multiple days without replacing it. They wear their soft contact lens, extended wear, they sleep in it all the time when it's a daily 1 week, 2 week, 1 month replacement lens. But the ocular surgery component here is really important. This can be a history of ocular surgery. The surgery could have been done many years ago, 20 years ago, 50 years ago. It doesn't matter exact timing. And that ocular surgery could be any type of ocular surgery. So we always like to ask our patients in the history if there's any history of surgery. Have you ever had a patient who said, "Oh, no, I've never had any surgeries before"? And then you look at their eyes and you say, "Oh, so when was the cataract surgery done? Or when was that refractive surgery?" "Oh, yeah, I had that done, a long time ago." But it can be any sort of surgery: cataract surgery, refractive surgery, retinal surgery, glaucoma surgery. And we need to be thinking about the possibility of NK with any of these surgeries. Oh, including corneal collagen cross-linking for any sort of condition, including keratoconus. So when we think about this, any patient who's had ocular surgery in the past, it really increases the number of patients that could be diagnosed with NK, which is why we want to be checking corneal sensitivity. So I'm highlighting just a few here. They're herpetic conditions, which are really highly prevalent, contact lens wear, abuse, and any sort of ocular surgery. Now, what about other etiologies? Toxic eye drops are huge. So we want to avoid preservatives like BAK. You see that big thing? No BAK. We want to avoid any sort of medications with BAK. And you can see here, many of the glaucoma medications do have preservatives and they can really affect that ocular surface. I've had a few patients, not a lot, but a few patients who've had topical anesthetic abuse, and these tend to be healthcare providers, either who work in, say, the emergency room or in veterinary medicine. That's where they sort of have access to topical anesthetics, and then all those CNS disorders too, including stroke. So we always need to be thinking about NK and putting that on our differential diagnosis. Other conditions here as well: chronic ocular surface injury or inflammation, and dry eye disease. Dry eye disease is highly prevalent. We see it in the general population. We need to rule out dry eye disease in every single patient. And that's something that we're going to talk about in just a moment, differentiating dry eye disease with NK. Here's some other etiologies. You can see that there are many, many different etiologies associated with NK. Let's talk about some diagnostic considerations. A pertinent history is really important. This is not just an ocular history, but also a systemic history. What sort of conditions does your patient have? Do they have, say, diabetes? Do they have a history of stroke? Is there anything that we might be thinking, could this be NK? Doing a cranial nerve assessment is helpful. Checking lacrimal function, so using a Schirmer's test which can be impaired, and that's tremors with anesthesia. Tear breakup time, checking osmolarity. If you have non-invasive imaging in your practice, go ahead and use that. A thorough eye exam with a slit lamp exam, with vital dye staining, with fluorescein staining, listening green. So look at the retina. Is there a history of retinal surgery, for example? I do have patients who come in who've had, say, PRP, and they don't report that. We do want to check staining. It's so important, not just for NK, but really for everyone. And if there is an epithelial defect, running a corneal culture, based on your practice, you might be doing this alone or you might be partnering with a colleague to do the cultures. In vivo confocal microscopy, we all don't have those in our clinics, but if you have the opportunity to do that, that's wonderful. And really looking for systemic immune disorders. So partnering with primary care or even different specialties, and neurology is a huge one here too. And most importantly, checking corneal sensitivity. So I'm going to say this a million times tonight, but checking corneal sensitivity is so important when we're diagnosing NK. So here you can see this really nice image. This is thanks to my friend and colleague, Chandra Mickles, where you can see the inferior corneal staining and conjunctival staining is more consistent with dry eye. NK has more of that diffuse staining or central staining. So we also want to look for fine corneal scarring. Sometimes it's not super obvious or previous signs of keratitis. So here you can see the differential between the two. But sometimes the staining can actually be really, really subtle. So that's why checking corneal sensitivity is so helpful. So when do we check it? Well, one, I mentioned we could check it in every single patient, but it's really recommended if a patient has an epithelial defect that's not improving within 14 days. If there's a painless epithelial defect, any sort of history of herpetic eye disease, a history of procedures that might have damaged the trigeminal nerve or conditions that could have involved the trigeminal nerve, including brain surgery, pain in the affected eye, and poorly controlled systemic conditions like diabetes. Those Parkinson's disease, also with a reduced blink, is another one. If there is an acquired limbal stem cell deficiency where we see sort of the haziness off in the periphery with the neovascularization or the new blood vessels, that's when we also could consider checking corneal sensitivity. Newly observed epithelial staining, and again, just poorly controlled diabetes. I know I've talked about that a lot, but this is something we really need to be thinking about in our patients for checking corneal sensitivity. Now, the assessment of corneal sensation is essential to diagnose NK, and there are many different ways that we can do this. So one is using a cotton tip, and some of my colleagues have taught me the importance of wearing gloves, taking a clean instrument when pulling off the edge of the cotton tip because we don't want to induce any sort of bacteria on that tip, but we can use a cotton tip to check corneal sensitivity. We can use dental floss. The really nice thing about dental floss is that we can specify the length of the dental floss. Of course, we do not want like minty dental floss. We don't want cinnamon dental floss. We want plain dental floss. And that's a great option. One option I've been doing quite a bit lately too is using the edge of a tissue because we can take a new tissue and just using the edge has been really easy to do when checking corneal sensitivity. There are also different techniques. The crochet bonnet is an option. There are different lengths. Not every clinic, of course, has this. The Brill non-invasive corneal aesthesiometer is another one. And the Belmonte non-contact gas aesthesiometer is a different way. So there are multiple different ways that we can check corneal sensitivity. And I think the main really important thing is actually to check it. So a question that often comes up is, okay, this is interesting. Like, how do you check it? Where do you check it? And you, it's very important to check each eye, definitely centrally, checking corneal sensitivity centrally, slash in the affected area. So say that they're staining in one area, it's not completely diffuse, you can see it more in one area than another, checking corneal sensitivity in that area. Of course, you could also do like the NEI sort of scale when checking corneal sensitivity, central, superior, inferior, nasal, temporal. There's a discussion about which eye to check first. I'll say both answers are correct. You could check the eye that is more affected or less affected first. But I think it's really helpful to check both eyes because the patient has an idea, oh, yes, I can feel that. And I like to tell my patients it might feel like a little tickle. Like I don't say, oh, I'm going to poke you in the eye. It's going to be really irritating, but it might feel like a little tickle, and you're going to feel this in your eye. And I hold eyes open. It's actually very easy to do, and it's really, really quick to do. Stating the obvious here, we do not want to apply topical anesthetic first. We actually want to check corneal sensitivity before any topical drops are applied. So here you can see, again, thanks to Dr. Mickles, you can see the cotton thread test, and the patient, they can blink a little bit, and they might notice there is a difference. So we want to ask, do you feel a difference between the two eyes? A descriptive scale is normal hypoesthesia or anesthesia, and using the blink response with caution because a blink can occur. So that's why I actually like to hold my patients' eyelids open when checking corneal sensitivity. Here you can see the Cochet bonnet, and the shorter the length, the greater the pressure needed. And sensitivity is quantified by the filament length. So checking the central quadrant is the most important for diagnosing NK. But I can't emphasize enough the importance of staining. So using staining when looking for NK and diagnosing dry eye, and in our contact lens wearers, staining is so important. Fluorescein staining is really helpful for the cornea. Lissamine green is great for the conjunctiva. I always say if you don't like your patient, use rose bengal because it's really irritating. But we like our patients, right? We like them for the most part. Schirmer's is reduced in people with NK. Tear breakup time is also reduced and osmolarity is increased. Confocal is helpful if it's available to you, but it's not necessary to do. And we can really check corneal sensitivity very easily, very practically in our clinical practice. So let's talk about the different stages. So the Mackey classification was used for many, many, many years, and I'll share with you a newer classification in just a moment. Stage 1 is rose bengal staining of the inferior palpebral conge, decreased tear breakup time, increased mucus viscosity, and punctate corneal epithelial fluorescein staining, which kind of resembles dry eye. Stage 2 goes straight to the epithelial defect, and this is the part where I really struggled with this Mackey classification because in clinic, I had these patients that were going between stage 1 and stage 2. They'd wax, they'd wane. One specific patient I can remember, she was monocular and with a history of GVHD, graft versus host disease, and she just kept going between the two, and I spent many a night worried about her cornea. The epithelial defect here in stage 2 is typically oval. And again, we're talking about the Mackey classification. Stage 3 goes on to the corneal ulcer. We can have stromolysis or melting and perforation, which we'd like to avoid. Here you can see how injected the eye is, the amount of vascularization on the cornea and conjunctiva. And this is the newer classification published by the Neurotrophic Keratopathy Study Group. And this one, I really like this classification because I don't struggle as much with like, oh, going from stage 1 to 2, it's quite a bit more descriptive. So stage 1 has the altered sensation without keratopathy. Stage 2 has punctate epithelial keratopathy without stromal haze. Stage 3 has a persistent or recurrent epithelial defect without stromal haze. Stage 4, we get to the PEK or the persistent epithelial defect with the stromal haze. 5 is the persistent PED with the corneal ulceration, and 6 goes to corneal perforation. So I like this classification because we can identify, evaluate the cornea. Is there stromal haze or not? Is there an epithelial defect or not? Is there corneal staining? And hopefully we will diagnose NK sooner rather than later and not ever get to the corneal perforation. Now, when we're diagnosing, again, that clinical history, the systemic history, the ocular history is so, so, so important. I think you can diagnose both dry eye disease and NK just with a history alone. Lacrimal function tests are quite helpful, that thorough eye exam, and checking corneal sensitivity. So the next question that often comes up is, there's so many different things out there. Where do I start? So let's start simple. Starting simple is removing any toxic substances. So this could be a artificial tear with preservatives. It could be a glaucoma medication with preservatives. So we could switch to either preservative-free or a surgical option. Removing anything that is irritating to the ocular surface. Daily eyelid hygiene. We talk about that a lot in our clinics, but it's so important. Using preservative-free artificial tears instead of ones with preservatives. We can also early on use things like punctal occlusion. We can use synergimen, autologous serum eye drops, therapeutic soft contact lenses, and other topical measures as well. So if there is significant inflammation, we might want to consider a topical steroid. If there's not an epithelial defect, we might want to add in an antibiotic. We could add in other measures. And I will say in my clinic, the scleral lenses come earlier on than maybe in some other clinics, but there are many, many different options. But really, if there's one thing that we can do to help our patients remove preservatives in these topical medications or eye drops. Autologous serum eye drops are really very helpful. So they're non-allergenic, non-preserved drops that are derived from blood serum. They contain many different components in them, and they can really induce proper proliferation and differentiation of the corneal epithelium. They help corneal nerve regeneration, and autologous serum can be used 6 to 8 times a day for the first month, and then we can taper it to 4 times a day. I've had many patients who have done quite well using autologous serum even with scleral lenses. Oh yes, if you have questions, put them in the chat. Thank you, Karen, for asking this question. Do you ever consider lifitegrast or cyclosporin in treatment? Yes, 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 yes. So all of the above, right? We have so many different topical agents that we can use now that are excellent to maintain that beautiful homeostasis of the tear film. So the more we could maintain it, the better. So that includes daily eyelid hygiene, it includes artificial tears, and really these prescription medications can help so much more. So thank you for asking that question. Keep the questions coming. Love it. Okay, we also have serum plasma therapy, which is quite helpful. So this has a success that can range from 70 to 92% within 90 days or less, and umbilical cord serum can be effective and has higher concentrations of substance P and NGF than peripheral blood serum. Epithelial defects are healed in 97.4% of patients with stage 2 and stage 3 NK using that Mackey classification after a mean 11 weeks of plasma-rich and growth factors. So this can be used in combination with different, actually, many things can be used in combination, but this can be used safely in combination with soft therapeutic contact lenses. And I will say that we'll get to that in just a moment, but they're underutilized. We have this great option to really protect that ocular surface. So here you can see with the autologous serum eye drops, patient's own blood is used, a blood draw is done, centrifuge down, separated, diluted, commonly 20 to 50%, refrigerated between use. This is good for 1 week, and it's important to freeze that additional supply. Some of my patients say that they really like that it's cold in the refrigerator. That feels very soothing to them. When using serum eye drops, of course, other eye drops can be quite soothing as well. Synergimin is a novel recombinant human nerve growth factor that is identical to the NGF protein that is produced in ocular tissues. So NGF plays a role in neuron development and survival, that trophic, the nutritional Pac-Man, think Pac-Man support, the epithelial cell proliferation and differentiation, and stromal healing. Here's the pivotal trial information. So you can see adults, again, using that Mackey classification with stage 2 or stage 3 NK. Patients were randomized to either synergimin or a vehicle, 6 drops daily for 8 weeks. Primary endpoints are neurotrophic lesion healing after week 8. So looking at the different studies, you can see an improvement in this synergimin group compared to the vehicle group, less than 0.5 millimeter lesion and 0 millimeter lesion. So at week 4 and 8, so definite improvement. And as you can see here, it is 6 drops a day. Safety, there are treatment-related adverse events in 43.5% of the treatment group versus 33.3% of the vehicle group. The most common adverse event was eye pain. Now, when patients come in and they're really not feeling anything, and then we get their nerves working again, yes, they can experience eye pain. So it's important to let our patients know that that is a possible adverse effect, that once things start working, that they might experience some eye pain. And there are many different ways to manage that. The Defendo phase 4 trial, this is an open label single arm trial of adults with stage 1 NK. Patients receive 1 drop 6 times a day for 8 weeks with follow-up at week 32. Primary endpoint was the percentage of patients with corneal epithelial healing at week 8. And here you can see the many patients did have that epithelial healing at week 8, 95.2% of patients. Additional efficacy outcomes are those who have corneal sensitivity improvement at week 32. More than 82% of patients do have that corneal sensitivity improvement. So I cannot stress enough that when we talk to our patients, we really need to counsel them that it is 6 times a day, because that is a significant investment in time for our patients, and talking to them about different ways to get the 6 times a day. For example, maybe you brush your teeth 3 times a day, so you could do it with brushing teeth, and then there are 3 other times a day. And also that when this drop starts working, that they might be feeling or have more sensation there. And that is completely normal. And I like to say, yay, it's working. That's wonderful. Here you can see some of the other adverse events with patients as far as severity of eye pain, mild, moderate, and severe. There can be corneal edema. These are in the treatment, the follow-up. Dry eye can occur. I won't make you memorize any of those. Let's talk about bandage soft contact lenses. So bandage soft contact lenses, sometimes we don't think, and I'm guilty of this too, I'm not thinking real high up like this is an option. But when I use these bandaged soft contact lenses, they're so incredibly helpful and they can really heal that epithelial surface. So the important thing is to replace them frequently. We want to talk about handling. So we want to make sure that a patient or their caregiver can handle them. And there's always, always, always a risk of microbial keratitis. So we want to be using a non-preserved topical antibiotic like moxifloxacin with the soft contact lens on, especially if there's an epithelial defect and if they're wearing it extended wear. We want to reduce the topical steroids and immunosuppressants if possible. But it's amazing, not just for NK, but for other conditions like significant corneal abrasions. We're even using a soft bandage contact lens for 1 day, using topical moxifloxacin, seeing the patient back the next day, and the epithelial defect or the abrasion is completely resolved. So I'm continuously impressed by, wow, how well they work. We do want to replace them frequently. Here you can see in our K-Pro patients, we do use soft bandage contact lenses very routinely. Of course, we also have scleral lenses that are quite helpful for many different conditions, including neurotrophic keratitis. Scleral lenses are large diameter gas permeable lenses, go over the cornea, land on that scleral conjunctiva, and they support the ocular surface. So they protect from anything external, dust, debris, everything. They prevent microtrauma. I would not say you should be prescribing scleral lenses as protection. It's still good to wear sunglasses, outdoors, safety goggles, things like that. But scleral lenses with that beautiful post-lens fluid reservoir promote corneal healing, and many studies show they improve comfort, quality of life. The added benefit of scleral lenses is that they correct vision too. So we can correct any sort of ametropia, myopia, hyperopia, presbyopia, astigmatism, dry eye disease, and we can protect that ocular surface. Now, when we're thinking about scleral lenses for ocular surface disease, there are some risks and there are some benefits. So we want to always avoid microbial keratitis, making sure that we are protecting the surface, especially if we're wearing the lens overnight, compliance with close monitoring. I always say the maximum ocular hygiene. So whatever you do maximally for dry eye disease, especially in a scleral lens wearer. So that could be eyelid cleaners, any sort of oral, say, omega fatty acids, using topical therapies for dry eye disease. But scleral lenses are helpful. They can be prescribed for short term, and of course, they can be prescribed for long term. We can have debris on the front surface of the lens, especially in those with OSD. We can have debris behind the lens. So that's why treating the entire ocular surface is so incredibly important. So let's kind of move on to other options here. Types of punctal occlusion. So there are many different types of punctal occlusion now that's helpful. So all of this, we want to really help the ocular surface maintain that natural homeostasis. And we can either this. One thing I learned recently is no studies looking at ocular inflammation and any detrimental effect of using punctal occlusion. So I think that when I talk to colleagues, and some of us were taught this in school, is that, oh no, if the ocular surface is inflamed, we can't use punctal occlusion. Well, you can. You can use punctal occlusion. It's possible to use temporary occlusion with collagen plugs. Sometimes I'll do this and then see my patients back in a few weeks, see if they noticed any benefit. We can move on to semi-permanent occlusion, so silicone or thermal plugs that can last months. We have permanent, or I always say semi-permanent occlusion with silicone plugs. These might extrude or migrate out of the puncta over time, which is why I say they're sometimes semi-permanent. And then we have other options now, like Lacrophil, that can actually fill up that puncta and last a bit longer as well. Moving on, we also have surgical procedures for NK, and my goal really is to diagnose early, protect that ocular surface, and try to avoid getting to the point of needing a surgical procedure. But here are some options. Oh, and amniotic membranes are also a great option for NK too. That it non-surgical, but using amniotic membranes. So other options are tarsorrhaphy or sewing the eyelid shut, a conjunctival flap, corneal grafts, or corneal neurotization. So let's talk about amniotic membranes. There are many different types of amniotic membranes. They can be used alone, they can be used with a contact lens, and these can really help protect that ocular surface and can be used to really seal up and get that beautiful surface and heal a persistent epithelial defect or any sort of epithelial defect that can occur with NK. Here you can see, I always like this picture. I think it's very visual. Love this picture here. But the different types of amniotic membranes. So we have cryopreserved that are stored at minus 80 degrees Celsius. They're stored in a media. And we also have dehydrated amniotic membranes that can be very effective as well. They're activated with sterile saline. And we also have sutureless or self-retaining membranes. But amniotic membranes are very, very beneficial for our patients who have NK. Across 16 studies, amniotic membrane treatment showed an 89% success rate in complete healing of that epithelial defect and ulcers in an average of 18 days. Corneal neurotization is another option, not as widely available everywhere. It does take a team, but this is something that is done in different hospital-based settings. And there are different ways of doing this. It's a very amazing procedure, which I'm just completely blown away that it actually works, but it does take coordinated care. And if you work closely with a corneal specialist or an oculoplastic specialist, a neurologist, this is a good place to start. Tarsorrhaphies. I sigh when I love when a patient comes in. Those of you I know who are on here who see a lot of specialty contact lens patients, and you see your patient come in with a tarsorrhaphy, and you're like, okay, what are we going to do now? Are we going to take down the tarsorrhaphy before fitting the lens? It's amazing how we can also fit lenses with a partial tarsorrhaphy. But there are many different types of tarsorrhaphy, which can be incredibly beneficial for short term. My patients have really not liked the cosmetic appearance of a tarsorrhaphy, and I like to avoid getting there, but there are times where just a short-term tarsorrhaphy is very helpful. So we can have a partial tarsorrhaphy where the lateral side of the eyelid is suture closed. We can have a total temporary tarsorrhaphy where the entire eyelid is suture closed. And there are different ways. So I have worked with different surgeons who perform different tarsorrhaphies, but when fitting lenses, it's always great to take down that tarsorrhaphy prior to fitting lenses. So there are also different investigational approaches for NK. Topical insulin is a really hot topic right now. This is looking at a small case series of 6 using topical insulin 2 or 3 times a day. And this was associated with a complete corneal reepithelialization in 7 to 25 days. In a retrospective analysis of patients with stage 2 or 3 NK in 21 eyes used 4 times a day, treatment was associated with a complete reepithelialization of a persistent epithelial defect or ulcer within 7 to 45 days with faster healing in stage 2 NK. Another different investigational option is using varenicline nasal spray. So this is an approved treatment for dry eye disease, and this really helps activate the trigeminal parasympathetic pathway. The phase 2 Olympia study investigated its use in NK, and data has not been announced or published. Now that we actually have a topical eye drop, I don't know of any studies for this drop that was just recently approved, but it'll be very interesting to see what the next few years show us to see if that is a different approach for NK. We also have different proteins found in tears and cells that promote healing. And this is looking at a phase 3 trial that was associated with a trend of complete healing in epithelial defects at 4 weeks in patients with stage 2 or stage 3 NK. And you, another investigational approach for NK is using a synthetic type of NGF in a phase 2 study in adults with stage 2 or 3 NK. Results are not available yet. So as you can see, there are many, many different options for treating NK. So we can treat with our basic options, avoiding preservatives. We can treat with things like immunomodulators. We can treat with all sorts of other things to really maintain that ocular surface. So what we want to avoid are any sort of secondary infection. We want to avoid microbial keratitis. We'd like to avoid recurrence, although we can use these therapies again, including synergimen, if there is a recurrence of, say, an epithelial defect. And the really important thing here is that we want to maintain the vision and diagnose early so that we can treat as early as possible. Here you can see the variability of NK and different pictures. On the left-hand side, we can see a PED that's healed with scleral lens wear. In the middle, we can see corneal staining in mild NK. And this is an image of a PED in a patient with GVHD. So let's talk about a case, a real-world case. So a 79-year-old male who comes into cornea at Will's Eye for a second opinion, diagnosed with conjunctivitis 3 weeks ago by the cataract surgeon using afloxacin 4 times a day. But 1 week ago, the epithelial defect was noted and a bandage contact lens fell out 2 times. So an option discussed was tarsorrhaphy. Here you can see the systemic history of atrial fibrillation. So an ocular history, again, we always want to be thinking herpetic. There's a history of shingles in the left eye about 20 years ago, history of cataract surgery, history of multiple retinal detachment repairs. So we have many, many different conditions here. And left eye vision was really poor at baseline prior to the conjunctivitis. And here you can see 2400 on the left, 2025 on the right. So looking at the external exam, looking for lag ophthalmos, so we always want our patients to close their eyes, looking for lag ophthalmos or incomplete eyelid closure, averting the eyelids, making sure there are no foreign bodies or anything like that. The patient did have moderate blepharitis, ocular rosacea, which is the telangiectasia of the blood vessels, which is so incredibly prevalent that we see in so many of our patients. And you can see the large epithelial defect here with about 15 to 20% of stromal thinning, diffuse conjunctival injection, and corneal sensitivity using the Q-tip method showed severely reduced sensitivity in the left eye compared to the right eye. And patient says, oh, it's about 20 to 25% in the left eye compared to the right. So because of the poorly healing NK ulcer, presumed due to a herpetic condition, many different things were discussed. So, of course, adding in oral Valtrex, it was helpful. Do we try another soft contact lens, tarsorrhaphy, scleral lens, serum? And you're not going to be wrong. You're going to start somewhere, you're going to see the patient back, and you're going to see really what works for this patient. But with this patient, kept on the topical antibiotic, added in erythromycin ointment to try and protect that ocular surface, using an amniotic membrane in this specific patient, Procara Plus. 5 days later, that epithelial defect was slightly smaller. Then 3 days after that, basically we're going smaller, 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 and we want to get to complete resolution. So post-op day 9, and I'm skipping some things purposely here, post-op day 9, starting Oxervate 6 times a day that day, and then continuing all the topicals, continuing the oral Valtrex, and finally here you can see getting to resolution. So we have the huge epithelial defect turning into corneal scar. We have some staining, but that's the real important point of diagnosing early, starting the treatments earlier if possible to prevent that epithelial defect. So we want to avoid preservatives on that ocular surface. We want to protect the cornea. And my goal for you tomorrow, if you're in clinic, or the next time that you're in clinic, is to check corneal sensitivity.